Thompson. So, hello, Vance Thompson here, and I'm, joined by two doctors that I get the honor of working with, Dr. John Gertz in Omaha and Dr. Cullen Ryburn in Billings, Montana. And welcome, you two.
Hey Vance, yeah, Colin Ryburn here. Thanks for having us.
Yeah. And our last episode was so interesting to learn from the both of you about your philosophies on diagnostics and preoperative screening, those important things. And now let's say that patient has gotten through your system and you're all ready for treatment and it's time for treatment. And John, you've seen some major advancements. I remember in the 90s when we talked about conventional treatments, going after sphere and cylinder. What are some of the advancements you've seen that have meant a lot to you as far as treatment modalities for LASIK?
Yeah, when we started, we couldn't even treat astigmatism. And so we were still making incisions for the astigmatism part of the correction. We went through a period of time where we did very small laser ablations. We got to bigger blends, but now we're at a point where we can actually map the surface of the cornea, create custom laser ablations for that patient, which is really got to the level of not only getting them out of glasses, but actually to the point that we're starting to improve quality of vision after LASIK. And that's ultimately what we've been working for the last, 25 years.
And I have to tell you, tracking technology also was a great advancement. Did PRK and LASIK for quite a few years without trackers. And so what that did for being able to introduce things like topo guided and make sure that that spot was placed where it was meant to be, married to the topography, was a huge advancement. And Cullen, this idea of going from blade to laser flaps, I think that was also a huge advance. And if I'm guessing properly, you've really enjoyed the laser flap era.
Yeah, I think the difference between the blade flap and the laser flap, it's remarkable because the bladed flap was supposed to be at a certain depth, but we know when we look at it on imaging that the depth that bladed flap went was highly variable and really can put patients at risk for having postoperative surprises and long-term complications like post-LASIK ectasia, where the laser flap is very precise and very consistent. And so from that standpoint, it's been quite a step forward. I'd say one of the largest step forwards in safety in LASIK over the last 20 years.
Well, and that loss of suction worry, with a blade going right to the surface with, a laser, you can just stop. It did, I agree, increase safety, tremendously. And so trying to decide who is going to get, wavefront guided or wavefront optimized or topo guided is not a super difficult decision. I think the main thing that I just want to emphasize is how robust PRK and LASIK are because of the excimer platforms, that we have these choices to match treatment. And I think that's one of the reasons we've seen such improvements in the quality of the ablations and also these wider ablations so that nighttime image quality is optimized. I'm going to dive into some, case examples because I know you two see a lot of refractive. Again, this first patient is going to be thin cornea, and everything else is normal. They're happy. You're happy with their expectations, topography, their epithelial mapping, their tear film analysis, and examination. They're ready for your recommendation. And 25 years old. They have a 490 micron thick cornea, and they're a -3 diopter myope. How are you handling that, John?
Yeah, so at a 490 cornea, I would not be comfortable doing LASIK. I think we have much better options. In that 25-year-old, I would lean towards PRK. I think that the results are going to be very much equivocal, but safety, there's no comparison. If he was a little bit more myopic, you would have ICL, options as well. We're just kind of on the limit of where we can do an ICL there. But I think at that level, I would still lean towards PRK.
Cullen, anything additional?
Yeah, I tend to agree. We think that thinner corneas at baseline might have a little bit higher risk of instability. I'd say that this patient, if they were asking my personal recommendation as someone who does see ectasia that filters from other areas of the state, then I think that doing PRK probably would be a little bit of a safer option. That's kind of my thought.
And I agree with both of you. Just a couple additional thoughts. Sometimes when we have someone who's borderline, because oftentimes, it used to be flap and laser, you want to leave behind at least 250 microns of the cornea untouched. And a lot of us then gravitated towards 300 for a couple reasons. One is the extra safety, but also if they have a little regression of effect, we want a little room for an enhancement. But you'll find with, some of these 500 corneas and, they, need to get back to, trying to be a highway patrolman or whatever, there's some pressure in these decisions, and PRK is maybe not working the best for their situation, that when you do the math in that 500 micron thick cornea, that they actually are in that 320 micron residual bed. So the math works for the residual bed, but it's still a relatively thin cornea, but it has a very normal profile. We'll just say this is why it's important that you have a yearly exam with topography, because most people are going to do very fine as long as they're not eye rubbers. But for that occasional person that's showing a drift, we can monitor if there's any behavior issues we need to do, but we can also strengthen their cornea with cross-linking. I tell patients the ones that are going to get in trouble are the ones that, 20 years later notice a visual change and they're like, I thought I better come in and get this checked out. They could have an early ectasia from eye rubbing or something that we could have helped them with. So monitoring, I think, is really important. And then, so let's talk about, and by the way, I just wanted to add that the ICL does come down to 3 diopters, -3. And so I know ophthalmologists and optometrists at 3 diopters of myopia have done an ICL. So I'm really glad you guys brought that up. We think about it for, high corrections, but it's actually beautiful for low to medium corrections too. And so I think it is worth thinking about. So let's say 6 diopter myope, Cullen, and they have a thin cornea and they're 25 years old, that same 490. How do you handle that?
Yeah, I think when we start getting into 6 diopters, it's going to be a discussion of LASIK is definitely not an option. And so with a PRK ablation would still be possible, but then kind of to me, one of the other things I look at is what's their pupil size, because their pupil size, particularly for night vision, at that ablation size, maybe their whole vision, their day and night vision would be better served with something like an ICL. And so I have that discussion with them and say, hey, I think these are our 2 options. Here's the pros and cons of each one. And I think either one of those would be feasible for that patient.
Wonderful. And John, so I'm going to challenge you, even though it's tough to challenge a master, but this is now 45 years old and similar parameters. You're happy with everything. They're a 6 diopter myope and they're happy with their nighttime image quality. And what are you going to do for that patient?
Yeah, so the discussion on thickness is the same. Definitely looking at PRK over LASIK. But now we have another issue of presbyopia. And discussing the near and distance vision with them, I think, is the key factor here. So our option is to do some monovision, which patients have been very, very happy with in the past. But we also, at 45, start to think about maybe lensectomy surgery. With some of the new multifocal IOLs we have now, they're just a game changer. We have studies, FDA studies, that showed 99.2% of patients are happy with the lens. That's the highest we've ever seen. of any lens, including the monofocal lenses. And so, really at that age, we're starting to talk about just going at it from the lens instead of the cornea.
Well, I'm impressed because I think we find it easier to go to the lens with hyperopes, but I'm impressed that you're talking lens option in a 45 diopter myope. So Colin, I'm going to ask you some of the retinal things that you would love to see cleared, if you will, for you to feel comfortable with a refractive lens exchange in a 45-year-old with a thin cornea and a little higher myopia.
Yeah, so with that conversation, I think one of the important things that I discuss with patients is that when you have that high of a prescription, your retina is always going to be at a slightly higher risk of something like a retinal tear or retinal detachment. And that goes whether we do surgery or whether we do not do surgery. Every single day that goes by, you're at a slightly higher risk. And so it's always important to be looking out for warning signs like lots of new flashes, lots of new floaters in the vision. On the exam, when I'm taking a look, I'm really looking to see, do they have areas of small operculated holes that suggest that they've already had some changes in their vitreous that's causing them to be at a slightly higher risk of having a tear or detachment with surgery. And if you see something that you're worried about, then it doesn't hurt to have your retina colleague take a look and weigh in on whether they think there would be some value in adding a little bit of protective barrier retinal laser. If it looks otherwise healthy, then it's just that continued conversation of saying, hey, these are things that exist for you every single day, so things to look out for, even if we decide not to do surgery.
I love listening to you guys think because you're presenting options that we've done for everyone. Just like you said, John and Colin, PRK is an option. Monovision PRK is an option. We've seen people be happy with that. We've also done lens exchange when we've done exactly what you just said, made sure the peripheral retina is good. And there's some great studies in how those patients that don't have lattice or the operculated holes that they can do quite well with RLE. So if we're ever wondering, we do get that retinal consultation, but there is some wonderful, options at that age. We all kind of, I think, have a similar philosophy for a 9 diopter myope. Once, I don't know what your guys' is cut off, but for me, once I'm getting to 7 or 8 diopters, I'm starting to think a lens-based procedure, whether it's a phakic IOL or a refractive lens exchange. How about you, John?
Yeah, absolutely. The issue always is first safety. And you can do LASIK safe at that level. However, the next issue is image quality. And I think there's always some decreased image quality in the very high myopic LASIK patients. And so, you're always inducing a little more spherical aberration than you'd like to. With the ICL or our IOL technology, the optics at the -9 are just so superior that even with a thick cornea, I'm still leaning towards that technology.
And Cullen, I'm going to take you into hyperopia. So you have a +4 diopter hyperope, 25 years old. Exam is checked out beautifully. Their manifest and cycloplegic are the same. So they are a true +4 hyperope. And I'm going to ask you, they have a nice thick cornea, whether two scenarios for that patient. One scenario, they're wearing their contact lens well, what would you do? The other scenario, they're contact lens intolerant with all the modern day contacts and pretty bummed in their hyperopic glasses, what would you do? First of all, for the contact lens tolerant patient.
So my personal take on it is for the contact lens tolerant patient, I'd really advocate that they continue to wear their contact lenses until they hit an age where presbyopia is really starting to bother them. There's just so much value in the natural lens that even with all of this new technology and all of the advances we don't have a way to replace the natural lens. And so really trying to get as much out of that natural lens as we can at the time. In the patient who has that 4 diopter hyperope intolerant of glasses and contact lenses, I think it's a really lengthy discussion with them because as we were discussing with image quality for high myopic treatments, it's the same for high hyperopic treatments. And that hyperopic treatment is going to be not quite as straightforward as someone who's like a -2 going in and having LASIK popping out and this is going to be great for a long time. It's a lot more variable. And so I think having that discussion with them, that the recovery process is going to be a little bit longer. We're going to have a little bit more time where we're seeing each other to really get to a good spot. So I think those are kind of the main things that I think about.
Me too. And these ablation patterns with modern day lasers have made a +4 diopter hyperopic treatment more predictable, but still not as predictable as a -4 diopter treatment. And so it's not like we won't do them, but it's the thought process, just like you beautifully described. John, I'm going to go into a case that happened to me the other day, and I can tell by both of your approach to refractive surgery in a comprehensive way. I think I know how you'd handle this, but I want to see how you think through this. This patient was 55 years old. They were a 2 diopter myope. They are correctable to crisp 20, and they're very interested in LASIK because their, wife had LASIK. And so I walk in and I ask this guy, if he's happy with his glasses and contact lenses. He says, I'm doing great. And so I'm feeling pretty good about LASIK. And, I do his exam, and, looking at a 55-year-old lens is not an easy, situation. Like I tell patients, as we get older, our teeth get yellow, our hair gets gray, we get wrinkles, and our lens gets hazy. And at what point of haziness do we call it, visually significant? So it's not always an easy decision. That's why that, what I call patient-reported outcome that we can get through history, is so important. So I lean back and I say, okay, you're in a construction zone. It's night. It's raining. There's other cars coming. How is your image quality? Are you hoping that what I do keeps that the same as it is now with your glasses or contacts, or makes it better? He said, wow, I was really hoping it would make it better, because I've noticed in that situation I'm not as comfortable. So this is someone who's correctable to 20, said he was happy with optical devices, but when we found a scenario, he's like, wow, my image quality isn't so good in that situation. How do you handle that, John?
Yeah, he's a tough patient to start with. 55-year-old -2s take off their glasses to read all the time. They don't realize how much they do it. And so, you always get that response, oh, doc, you don't understand. I can see fine up close. I just need the distance. In this case, glare testing is going to be key. Take them and we glare test everybody, over 50 years old to see. And very commonly, the patient doesn't realize how much that glare drops their vision down. You show them in the glare testing device, how much it regresses. And so I think this patient, would benefit from lens replacement just based on their night vision complaints. But we can also address their presbyopia with a multifocal. Now, in the past, somebody comes in with night vision complaints, and now you're putting a multifocal lens in that might have a little bit of the night vision issue. We were always hesitant. With the new lenses, the glow they get at night is so minimal in comparison to what they see with early cataract that even some patients that complain early on, long term, it's just not the main issue that we're dealing with these lenses. And so, definitely a guy I would go with lensectomy surgery on, and somebody I wouldn't be fearful of a multifocal IOL.
Well, interesting you say that, because that's what he ended up choosing, and he ended up being wildly happy. So that nighttime image quality really was a game changer for his situation, and the modern day multifocal did make him super happy. So I want to thank you guys for this discussion on this comprehensive approach to some of these cases. Some of them you chose PRK, some you chose LASIK, some you chose phakic IOL, some you chose lens replacement. Bravo. And to the doctors out there that we get the honor of working with, I'm actually amazed how, you get to know these patients, and some of you will call me and say, I think this is a better lens replacement patient, or I think this is a better phakic IOL. If you're considering corneal refractive surgery in this patient, just remember, they didn't do the best with monovision. So we get these wonderful tips from all of you, and just remember the many fellowships with us where you can come spend time and see these patients going through the process with us. We just love you coming to see us and us learning from you also. So, John, Cullen, thank you for how awesome you are and this, fun discussion on not only some of the treatment things that we do and different modalities, but just how you handle different cases.
Thank you, Vance.
Yeah, thanks, Vance.